year after year, consistently, the ones who obviously are enrolled in direct primary care have lower claims costs than those who aren't using it. So we know it works, especially even, now that we have 3-4 years of data to look at. It's not even just a 1 year snapshot. And even as a population as a whole, because we don't have 100% participation, but even if we just look at their claims as a whole, we see it going down in that 3-year period that they've had it. And we compare that to the 3-year period prior. Both the employee and the employer costs are down 12%.
Hello, everyone. Welcome to another episode of the Healthy Savings Podcast. I'm your host, Sasha Gurvov. I'm the co-founder of Milu Health, and I'm joined today by Greg Humkey, who is a benefits advisor with Employee Benefit Associates. Greg, welcome aboard.
Yeah, thanks for having me, Sasha. I appreciate it.
It's awesome to have you on. We've been lucky enough to work with you and Christina over the past months and build some really cool stuff together. And we're excited to chat with you here to hear about what you guys see in the Kentucky market, how you've built EBA over the years, what you're most excited about, what are some wins, all that good stuff. But maybe to get started, can you just give a little bit of background on yourself? How did you get into the healthcare world, and what motivates you about it?
Yeah, well, probably like a lot of people who end up in the business, I followed in my dad's footsteps. It was a family-owned agency, and so that was a step I took out of college. It was interesting. I actually, in college, if I take a step back, during the summers in college, I actually sold books door to door. That was my summer internship.
Like textbooks or like encyclopedias?
Yeah, like educational textbooks kind of deal, where it would help kids with like their homework. So if they're having trouble with like math, you can flip to the math section and like break down how to do the math problems and stuff like that. It give them like sample science projects, stuff like that. So educational books in the summer. So I did that for 2 summers in college, and like absolutely terrible, but it was like absolutely terrible, but it was great in the standpoint that like it just helped me grow as a person, right? It helped me realize like you can do hard things. You can, it's good to be entrepreneurial, own a small business. And so naturally, when I got out of college, I was the youngest of 4, and really the only one that had any interest in being, a small business owner, taking over the family business. And so I made that leap into the family business. My dad had a benefits agency, and I got into the business really just doing a lot of individual health insurance because, I didn't feel super confident as a 22-year-old going into a large company saying, hey, like, let me do great things with your health insurance. I just didn't have that confidence. And so I still to this day, because a lot of the conversations we have is around just the cost of healthcare and health insurance. It's really interesting. I remember when I purchased my first like individual health insurance on myself, because we were, a small family agency. We only had like 1 or 2 employees at the time when I joined. And so we didn't have a group health plan. Everyone was just covered under their spouses. And so, at that time, when I think of, what drives me, I remember I paid $75 a month for like a health insurance plan that had a $1,500 max out of pocket. So like all in, like I would have been out in a bad year, like $2,400, right? And so it's really interesting. I always go back to that because I like to check in every once in a while, even though I don't do individual health insurance anymore, just like what healthcare.gov's cost is, right? For an individual health insurance plan for a 22-year-old. And it's interesting, fast forward to today and a young 22-year-old coming out of college, if they're on the hook for purchasing their own health insurance, like on healthcare.gov or the exchange, it's more like it was over $600 a month this year, and the out of pocket's over $7,000.
Wild.
So you're talking like a 5x, increase. I can't imagine being a 22-year-old kid saying like, hey, you're potentially on the hook for, up to $14,000, $15,000 a year in healthcare expenditures. It's just crazy.
That's crazy. Well, it's interesting. Maybe a year and a half ago, we were doing some research on ICRAs, and there's a lot being published and still is about, hey, are ICRAs going to take over the world? And is everybody going to just buy their own insurance. And I don't know. I actually feel like if it goes in that direction at some point, like it could be a really good thing. People will have a lot more skin in the game and responsibility, and we'll do a lot more research. And there's good benefits that'll come from that. But I did the same thing. I went on healthcare.gov. I bought a plan. My wife and I, right when we got married, we spent a year traveling. We were living abroad, and so we bought a plan on healthcare.gov. Then I don't remember what it cost. It was affordable enough. And I looked at it recently, and for any kind of number that would be affordable, the deductible was going to be like $5,000, $6,000, $8,000, $10,000, and you're just kind of like hoping you don't use your health insurance at that point.
Yeah. Just, cross your fingers and hope you don't get sick, I mean, I saw a friend post on Facebook recently, like, if you want to have any money at all, like, don't get sick. So clearly something happened. They must have just had some sort of medical emergency and they had to use their health insurance, and it probably wiped them out, because it's like, that's the norm these days, is for younger people to take on those higher deductibles, right?
100%.
There's and that always makes me think of a book that I read, not too long ago from David Goldhill, like Catastrophic Care. I don't know if you've heard of that book.
I've heard of it. I don't think I've read it. I think I have it on my bookshelf, actually.
Yeah. Well, there's just one chapter in there runs the numbers on what, like, a younger person, millennial type age person in his company would pay over the course of their life in health insurance, healthcare, the premiums, the hidden costs, what the employer pays on their behalf, the hidden costs via like taxes, Medicare taxes, all that good stuff. And it's, half of your lifetime earnings. And when you hear that, it's like, no way. Like, there's no way.
Yeah, that's my reation right now. Like, I've heard all this stuff. That can't be right.
It's like, no way. But, the CFO went through, ran the numbers and does the math. And I can kind of see it now. I mean, when I look back and we look at, when I go back to my story and look at, like, when I was, 22 and paying that, and then look to what it is today, I can kind of see it, And then when you think of, the hidden stuff that, not to get political, but everyone wants to talk about, this time of year, you have the budgets going on and, the politics around getting the budget and the national debt. And it's like, you fix healthcare, you might have fixed that. You know what I mean?
Well, this is taking us way off topic, and not to get into politics, but I feel like it's business and not politics. I just saw a graph yesterday. It was like Medicare spending, defense spending, and then interest expense for the federal government. And like, it was like this, and like interest expense this year, I think, is above Medicare and defense, which is wild. Like, party aside, like and I get it, a higher interest rate environment, I'm guessing, drives that, whatever. But like, we gotta solve medical costs. Defense, I'll leave to other people to talk about, and we gotta solve interest expense. Your selling books door to door story is funny. I was thinking back to my stuff, and this was before college, but I did the newspaper route. I was afraid of going door to door, so I just sat in the bike and then tossed the local Sun Messenger and hope I didn't break anyone's stuff.
That was smart. You were safe from there. Yeah, that was smart.
It didn't pay so well, but that's all right. Well, I'd love to chat about EBA and the types of employers you work with, and what you see out in the market. Like, what's healthcare like in Kentucky, where you guys are based, and what are some of your employers like? What are their populations? What are their needs? What are they looking for? What problems do they have?
The way we operate is really trying to come from just a very custom approach to say, look, every employer's a little bit different. They're in different areas of the state of Kentucky. We have employers here in like central Kentucky, where I'm at in Lexington. We have employers in like, rural, like eastern Kentucky and so forth. And so, whenever we're looking at an employer's plan and working with them, it's a little bit different by employer, because they have access to different providers, different tools based on their area and their employee population. For the most part, you kind of think it's the same, so many diabetics, so many hypertensives, XYZ, but you still get, these pockets of where we see, employers broken out with higher comorbidities versus those just with maybe they just have a specialty drug spend issue. And so we just look at the data and say, okay, what is the data telling us? Like, let's just get your data, let's get your information, let's see what it tells us, and then let's come up with a strategic game plan from there. What's the low hanging fruit, right? That we can just maybe have the least disruption to employees, that we can go after the most. And just try and start that conversation from there and create like a multi-year game plan of just addressing the low-hanging fruit to start.
And when you guys get started, and I'm sure this differs employer by employer, geography by geography, employee type by employee type, but like what's usually the foundation? Like what's the first low-hanging fruit that when you see it as an opportunity, you're like, this is just a no-brainer. Like, we got to start here.
Yeah. So the two biggest is generally obviously pharmacy. I mean, pharmacy's just completely out of control. And another one, if it's available, is primary care. And so, one thing we saw with one of our local employers here in Lexington is that they had, even more higher than most population of employees that had, multiple comorbidities, right? Diabetics, hypertensive, hyperlipidemia, and they were often had all three, and some other things lumped in there. And so we knew that those employees, more than anything, just needed like really good primary care, right? Because if you think about today's primary care model, it's just not really working, right? Because employees get punished every time they go. They have to pay a copay, or if you're on an HSA, it's part of your deductible. And so you get punished every time you go. Plus, it's just annoying because you're sitting in a waiting room, waiting for a long time. And you go in and you maybe see your doctor for like 7 minutes or 10 minutes, and you just really don't have a relationship with them. And
you probably had to schedule it a year out.
Exactly.
Or something like that.
God forbid you get sick, because, they may get you in the next 2 or 3 days, but, rub a lamp, like you may not. And so with direct primary care, one thing we're doing is when available. So, and thankfully in our town, we have a great clinic with a couple MDs who just do an amazing job from a clinical standpoint. And so we put this in place with one of our employers here, with a lot of our employers here, but the one I'm thinking of specifically, who had just a lot of unhealthy, lifestyle type conditions going on within the group, just immediately saw significant impact to that population base. I mean, for one, most employers, look at you and like, I'm not, my employees aren't going to want to change their doctor. Like, they trust their doctor. They like their doctor. And I'm like, trust me, the system's broken. Like, let's just give this a chance. And so, what we found is that when we put that in place and really put a lot of education behind it, like, we actually had the docs come into our open enrollment meetings, meet employees face to face, talk with them. We saw significant enrollment, participation rates of, 50%, I think the first year, and 3 years in more like 70% participation. So,
and that switch your, like, that is switch your PCP to the direct primary care.
Oh yeah. Yep. So these are, 70% of the population now is essentially fired their primary care doctor saying, hey, like, I've bought into this, direct primary care clinic who, by the way, will text me when I text them, right? Like, I was with an employer the other day who we put this in, and he's like, I will never go back to the regular fee-for-service primary care model. He's like, this morning at 6 a.m., I texted, Dr. Cooper, who we work with, about this issue I have going on, and he immediately responded back. He's like, no one gets that, right? No one gets that. It's just like a level of communication that most people just don't get in the regular fee-for-service, primary care model.
I switched my primary care doctor recently. We moved. There's a big system next to me. It's the only one I know. And, I've had one appointment, and they're lovely, and I think they're a really good doctor. But, like, to get in touch, I'm logging into my chart. I'm sending a my chart message that's going to their nurse that then gets forwarded to them. And, like, that's not texting with someone when something goes wrong. And I get it. At a big system, like, that's the only way to do it. But that's not what I think primary care was 50 years ago. And it's pretty cool to see that making a comeback.
it works really good when it's available. I mean, the downside is going back to like what our population or what our client base looks like. I mean, we have clients in Eastern Kentucky where we just don't have access to clinics like that in their area. And it's just unfortunate, right? Because, that's just not a lever that we have to put in place for those employees to really help them out. And so that's just an example of, when it's available, like, my goodness, like put it in, like it's going to work. It's going to be a benefit that members love and that they're going to take advantage of because, why wouldn't you just give them an option? You're never going to get 100% participation, but I think people will be surprised and even financially. I mean, we look at we track the data on the claims data on all these members. We'll do different cohorts, right? Those who use, direct primary care, those who don't. And, year after year, consistently, the ones who obviously are enrolled in direct primary care have lower claims costs than those who aren't using it. So we know it works, especially even, now that we have 3-4 years of data to look at. It's not even just a 1-year snapshot. And even as a population as a whole, because we don't have 100% participation, but even if we just look at their claims as a whole, we see it going down in that 3-year period that they've had it. And we compare that to the 3-year period prior, both the employee and the employer costs are down 12%. And they haven't changed the benefit design. The benefits design's been the same as it always has been. And I'd say that's probably the biggest contributor for that specific employer because that was like their problem, right? That they needed fixed. And yeah.
Do you have a sense for how widely available direct primary care is throughout the country? Like at this point, is it like if I pick a random big city, is there a DPC practice that you could do, or is it still pretty sparse?
Yeah, I'd say if you pick a big city, there's definitely going to be some availability. There's a mapper online that actually is super helpful where you can plug in like your zip code or your city and it'll bring up, and some of it I've noticed is like, because I use it from time to time just to see based on where our employees are, our members are. And every once in a while I'll see it's a little bit outdated. Where a clinic may have closed down and we try and reach out to them and they're not open any longer. But when I check that from time to time, what I find is that any decent sized city, it's going to be pretty available. Where you run into trouble is your rural areas. But even in some decent sized cities, there's like maybe 2 or 3 clinics. I mean, our town is, fairly large and we have 2 like what I consider really well-run MD type clinics. And then you see the other movement in this area that you see is a lot of national firms creating a similar type model that's run with, nurse practitioners, PAs, that's very focused on the employer market, which is better than nothing, but it's not as good as like, hey, like I actually have an MD I have access to at any time. So it really just kind of depends on the area.
And then how do you think about in-person versus virtual? I've also seen, there's a lot of like virtual DPC solutions out there. In your experience, have you tried that? Do you see a big drop off?
I haven't tried it. I've spoken with a few and I've tossed it around in my mind a little bit. And I feel like it could probably work pretty well because in theory, I mean, if I think of my personal primary care physician that I'm set up with a DPC clinic here in town, and honestly, 90% of my stuff is virtual with him. And only 10%, literally 10%, I might have to go in his office for something. When he needs to check my blood pressure, draw my blood, that's the only time he actually sees me. Granted, I'm thankfully in good health, but so I could see where virtual direct primary care can be effective, but I haven't had the opportunity to really test it out and see for myself.
And in-person matters. Like at the end of the day, healthcare is healthcare. People want to see their doctor. So there has to be some element of that. I don't know if someday in the future there's some solution that's like, I don't know, they share even if they're not affiliated, they share records and maybe you got 2 docs. You got a doc in the cloud and you got, Dr. Smith who you see all the time. Like maybe it'll go there. Who knows? How about, you said pharmacy was the other kind of blocking and tackling. It's obviously a huge hot button for everyone nationally, for employers, for patients. How do you guys think about that stuff? where have you seen that you can actually impact those costs?
It's really an interesting game because it's one that if you look at the data on employer plans and where their money's going, I mean, I think when I first was in the business 15 years ago, pharmacy might have been, 10, 15% of a plan spend, right? And now it's, 30, 40% of a plan spend. And it's just continuing to, grow faster. The pharmacy trend is significant compared to even what medical trend is right now. And a lot of that is because of all the specialty drugs, the high cost medications that are coming out. And so, but the good news is that that's usually the easiest bucket to address, the easiest lever to pull. And there's a lot of things we do around that. But, one group that we're going to be working with together here soon, we moved over to from a fully insured plan to a self-funded health plan. And it was interesting. They had, it's a large dealership with 250 employees. Of those 250, they literally only had 50 on their health plan because of pharmacy. Basically, they had, 9 individuals on specialty meds out of those 50 employees. It was driving 70% of their cost. And they had just consistently received 30% increases year after year after year from their fully insured carrier. And to the point to where it's driven, unaffordability for the rest of the population. And it's driven, most of the rest of the employees off the plan. And so, with those type of scenarios, we just put in place guardrails, right? Steps to say, hey, are these the most effective drugs? Are they really the proper drugs for you? Maybe they are. And if they are, then, how can we source those, better? And for this specific employer, 8 of 9 employees, we sourced through a manufacturing assistance program where we were able to get that at no cost, both for the employer and for the employee. Just like that, just completely removed off the plan.
That's wild, by the way.
And to think all these years that they've been overpaying, when in reality, it just took a little bit of data, understanding what's driving your cost, and there's solutions to every problem. Let's just put a solution in place to help these members and the employer save money.
And I mean, those employees must have been paying, I don't know, $100 a month at least for specialty drugs on a plan that wasn't cheap, right?
Oh yeah. I mean, under this particular plan, when we picked them up, they were paying, 25% of the cost of the med to their max out of pocket. So if you think about it, 1 month fill and they've met their $4,000, $5,000 max out of pocket, right? These employees are paying significant amounts of money for these. And so it's really a win-win both for the employee and the employer. And so, I mean, we were actually just sitting in our renewal meeting with them yesterday, going through the first 9 months because we're coming up on renewal. So we were reviewing the first 9 months of their claims data with them. And although we're still pretty early on in the process, we've reduced over these 50 employees their pharmacy spend, like $475,000.
That's insane. That's insane. I mean, as a percent of total spend or total pharmacy spend, that's got to be a significant number for a group of 50.
Yeah, it was like 85% reduction. That's kind of more of an extreme case. It's just top of mind because I was meeting with them yesterday, but I'm just like, how much of that is out there and is going on? I feel like, probably more than we think.
What happens next? Does the plan price come down for all employees? Does it just become more sustainable?
Yeah, what's funny is now, I imagine the conversations that I used to have probably 5 years ago before we started building these types of plans, and it was like, hey, good news, we got your renewal down from 30 to 20%, right? And yay, this is so great, and here this year, literally the employer's trying to decide how much do we lower payroll deductions? Should we lower it 20% or should we lower them 50%? Right? Do we
insane.
Do we do 20% and put the savings in reserves in case we do have a bad year next year? Obviously you can't predict everything that's going to happen, and they may have a high cost claimant hit next year. So should we reduce the payroll deductions 20% and put the rest in reserves to help offset future renewals? Or do we just go ahead and pass the savings off now and reduce payroll deductions 50%? Right. That's a much better conversation to have with that employer when we're trying to figure out like where do we set those for the coming year now that we're going through renewal.
By the way, just for everyone watching, like this has to be like a top 1% of employers in the country type of example. There can't be many of these conversations going on throughout the U.S. around like, no, we're not going to increase 30%. We're actually going to drop costs, and you get to decide if your employees pay 20% less or 50% less, and make the plan more sustainable next year. Like, that's amazing. As you think about other groups that you're talking to, maybe let's take groups that like haven't switched over yet, are less open to doing something new. What do you see as the kind of key barriers or key conversations to have with employers? Because part of me says like, oh my God, you listen to those two examples, like you put a DPC and you drop pharmacy spend that much, like it's a no-brainer. So like when folks hesitate, like what are they talking to you about?
Going back to this employer we were sitting down with yesterday, because this is their first renewal working with us under this type of plan. And, they said like, look, like we were really skeptical when you were in here a year ago talking through these programs and these ideas and what we might expect. And they're like, our eyes have really been open. Like this is serious stuff. And it actually works. I think the downside is employers have been promised for so many years by their broker, like, hey, like we can save you money and we're going to do this and we're going to do that and it's going to save you money. And they're just very skeptical because they've been burned, right? Because, there's been a lot of just unfulfilled promises in our industry. I guess my point to that is really just there's a lot of innovation in healthcare, I think, coming. And there's a lot of silver bullets in healthcare. I mean, what I think of what's worked with our plans and going back to like direct primary care and the pharmacy programs is the program that works the best is the one that gets really good utilization, right? Really good utilization. You have to have the employees that buy into the programs because there are a lot of silver bullets. It's just a matter of actually getting utilization into those programs, getting employees to buy into those, whether that's, we started a nurse navigation division where we have a nurse on staff that's working with employees to really educate them about the different programs, take their questions when they have, hiccups and it doesn't go exactly to plan. It's just making sure that, hey, there's a lot of good things going on out there, but we really got to drive utilization into the programs because otherwise, it's just going to be another unfulfilled, promise, really, to the employer and to their employees.
Having your own nurse that they can call is huge, and I think it's one of the first things that you and I talked about when we met. You guys were just starting that, building it out. And by the way, I don't know if I believed it at first when you said you were doing that because it's novel. Like I don't know of many other advisors that have brought a nurse onto staff and created that kind of program. How'd you guys get there? Like what made you go down that path? How'd you make the decision to jump in and say, no, we're just going to go do it?
We didn't invent it, right? I can't take credit for inventing it. There's been, definitely a few other advisors before us that have gone that path of saying, look, it makes sense to just bring this piece of the puzzle in-house, right? So we have a little bit more control over it so that we, can bring them into our enrollment meetings so that, again, kind of going back to the DPC, so that members can sit knee to knee and put a face to a name with the people they're going to be helping them as part of their plan. I think I'm not super innovative and the most creative person, but I think when I see an idea that makes sense, I'm just like, well, crap, like we can do that too. Like, it just makes sense. Like, let's just do that. And so that was it for us. I mean, when I think about how a nurse is a trusted professional for employees, similar to a physician in their healthcare journey. And when you're rolling out programs where employees are a little bit skeptical, and they need that additional hand-holding because let's be honest, healthcare is very clunky. It's hard to navigate. And so it was just an easy decision for us to say, hey, like it makes sense. Let's just take a leap of faith, make the investment, and hopefully our clients will come on board. And obviously the work that nurse does is highly dependent on, programs like even like what you all are doing. Like, how can we, work with different partners to be able to identify, cost savings programs, healthcare programs that can make a real time impact. The earlier, the better, right? And the fact that just, with like when you were telling me what you guys were doing, I'm like, we could find out before the pre-cert. Like, that's like, no way. Like, we can't. Can we really find out before the pre-cert? And you're like, yeah, we can find out before like the pre-auth comes in. Like, we'll be the first. Like, we'll catch that as it's happening. And I'm just like, mind blown. Like, I'm sold. Like, let's do it.
Well, it's funny because from our perspective, we sit here and we're like, oh my God, like there's what the world looked like a few years ago, which is not super innovative in terms of new health benefits, some stuff on the horizon. And then you look at like today, there are dozens of different things you could do to improve the health of your employee population and reduce costs. In any category, there's going to be the ones that are amazing. There's going to be the ones that are so-so, but like there's a lot of stuff out there. Musculoskeletal programs, centers of excellence, durable medical equipment, like you name it. But no one knows about it. Employees don't know about it, and they don't find out about it in time. So if there's some way to drive that in a real way, could move the needle.
Exactly, right? It's utilization, right? Getting them to like drive those programs to them, right? Getting them to get involved in those programs, right? And that's the key. It really is.
Amazing. Well, I, for one, am super excited to see you guys continue to grow it and make a immense impact in your communities in Central Kentucky and beyond.
Yeah,
so thank you. Thank you for coming on the podcast.
All right. No, thanks for having me, Sasha. It's always great catching up. Appreciate you.
Thanks for listening to Healthy Savings by Milu Health. If you would like more information about any of the topics you have heard today, we would love for you to get in contact with us. Find us on the web at miluhealth.com.